Hey everyone, welcome back to Heart Health with Michelle. Today we're going to talk about atrial fibrillation, prevention, and heart health. And I'm so excited to welcome Dr. Dabhed Kar to my YouTube channel. I'd love for you to introduce yourself, tell us a little bit about who you are, and then we'll get right into our exciting topic for today.
Absolutely. Thank you. Thanks for having me. I'm really happy to be here. And I'm happy to be talking about a topic that's really close to my heart because it constitutes probably half the patients that I see. So I'm Kaustubh Dabhed. I'm one of the cardiologists in a large group practice in Charlotte, North Carolina. And my practice is mostly focused on preventive cardiology. And it includes both primary prevention and secondary prevention. So secondary prevention is where you have already been diagnosed with heart disease, and now you're trying to prevent more episodes or recurrence or further worsening. So my patients are mostly patients who are interested in avoiding heart disease. So we do risk factor management. And then the other group of patients is where they've already had atrial fibrillation or abnormal heart rhythms or blocked arteries, and they're looking to prevent more episodes or prevent worsening of the disease. So that's mostly what I do.
Excellent. So let's get right into atrial fibrillation. What is it? And we'll talk about why it matters. What is it that causes an increase in stroke, and why is that? I really think it's important to understand what's happening and why we want to keep it in remission and make sure that we are controlling it as best we can.
Absolutely. Let me switch to my iPad. So hopefully I can share a cartoon and draw a little bit.
Perfect.
Okay. So this is my drawing of a heart. So the top two chambers are called atria, and the bottom two chambers are called ventricles. Now, we don't have to remember any of this. So let's talk about the heart rhythm. So the heart rhythm typically starts in the top chamber called the right atrium. It starts here, and it's called the sinus node. And the heart rhythm then travels down using various pathways. So essentially, this part, the sinus node, acts as the command center that tells the heart when to beat, and then the rest of the heart follows in a coordinated fashion. Now, the unique thing about the heart is each little point on your heart is capable of generating a heart rhythm. Because just because your command center fails, you don't want your heart to stop beating. So the heart is pretty unique in that way, where anything can start a heartbeat. In atrial fibrillation, what actually happens is multiple points in the heart get activated at the same time, and thousands or millions of these points get activated at the same time. And all of a sudden, they start sending multiple signals to the heart rhythm system, overwhelming the system. The good thing about the heart is it has a lot of backup mechanisms and a lot of control mechanisms. So there's a control node here called AV node, which controls how many heartbeats actually go down. So your heart won't actually beat at like 600 or 1,000 times a minute, but the bottom chambers of your heart may beat at like 100, 120, 140, or even 60 or 70 beats per minute, but it's pretty irregular. So what happens when the heart beats irregularly is there's a tiny chamber in the heart here called left atrial appendage. You can remember it as a tiny cave. That's how I like to explain. And when the top chambers are not beating in a coordinated fashion, blood can actually start accumulating in this chamber right here. And it can sit there and eventually form a clot. And then when the heart goes into a normal rhythm, this clot then gets pumped out, and it can then travel to any part of your body, causing a blockage in blood supply. I mean, the thing that we worry most about is obviously stroke. So stroke is one of the biggest risks of atrial fibrillation. Atrial fibrillation as a heart rhythm is rarely life-threatening, but can be significantly debilitating by causing impact on quality of life in general.
Yeah, thank you so much. That's really important and helpful. I think it's important to note that what we're most what's the word I'm trying to use? We're really trying to do is prevent that blood clot from forming. And so when when AFib is not managed and controlled properly, the risk of a stroke is very high because that's where the blood supply is going first. And so we need to be and it can also, like you said, lead to a heart attack too, but it's much more common as a stroke because that's where we are pumping blood to facilitate that good blood flow. So an often question that I get though, and I think that this will be helpful, is many people feel that irregular heartbeat, they go to the physician and they are diagnosed with PVCs, or they're like, it's benign, you have nothing to worry about. Can you explain the difference between atrial fibrillation and PVTs or SVTs, in how what does that increase the risk of heart disease? Why is it different?
Absolutely. So let's go back to our heart model here. So essentially what I've shown is atrial fibrillation, where everything is sort of beating in an uncoordinated fashion. Now, when you think, so let me delete some of these things so we can start talking about SVT and PVCs a little bit. So as we discussed before, each little point on the heart is capable of generating a heart rhythm. So what happens with PVCs is a random point in the bottom chamber of the heart, called the ventricles, start sending additional signals to the system. And these sort of manifest as, some people may describe it as skip beat or an additional beat. And these, based on our understanding of atrial fibrillation, these do not necessarily increase the risk of atrial fibrillation by a whole lot. What we have to remember though is, one, each person is different, so it's going to be a little bit different for everyone. There are some situations where PVCs can cause atrial fibrillation, but those situations are rare, and we shouldn't even be talking about them in a common setting. So for general patients, I tell them PVCs, atrial fibrillation, unrelated. Now, SVT is where some point in top chambers of the heart, could be 1 point, sometimes it could be a couple of points, start sending additional signals to the AV node. Now, what we know is SVTs do increase your risk of future atrial fibrillation by a little bit. But just because you have SVT does not mean you will get atrial fibrillation. There's some increase in risk though with that.
Great. So let's talk about prevention. So there are many risk factors that increase someone's risk for AFib. And I think it's important that we discuss it. Some of them are more commonly known, but some of them are not as commonly discussed. And I think it's important we bring it up to increase awareness and make people more aware, and also more proactive of how we can manage them to put AFib into remission, or if you don't have AFib at all, to prevent that from happening. So let's go into that and see, and have that good discussion.
Absolutely. So, when we talk about prevention, you bring up an interesting point about the risk factors, the common and uncommon risk factors. So when we talk about prevention, what we do is we identify the risk factors in a particular patient and try to control them, hoping to sort of get rid of the AFib at the root cause instead of waiting for AFib to develop and then treating it. So when we think of risk factors, we typically divide them into two groups. The first group is non-modifiable, which is something that just happens, like age or genetic risk factors that for practical purposes, you cannot really modify. Age is one of the biggest risk factors. Once people start getting beyond the age of 65, 70, your risk of atrial fibrillation goes up. In fact, there's some data that mentions that 1 out of 4 people beyond the age of 80 have atrial fibrillation at some points. A lot of it actually goes undiagnosed. So age is the most important risk factor. Genetics is another risk factor, and those are incompletely understood. But if you have family history of atrial fibrillation, you're at an increased risk. So these are non-modifiable. And then when we think of modifiable risk factors, we have our traditional risk factors like high blood pressure and diabetes. or blocked blood supply to the heart, which we also call coronary artery disease, or heart failure, where your heart is overwhelmed with fluids and it cannot deal with it. So these are sort of your traditional risk factors, and we focus a lot on preventing those. But some of the ones that you alluded to, which we don't address as often, or, those are sort of like, oh, yeah, let's take care of it instead of focusing on those. And so some of them are sleep apnea, amount of alcohol intake, amount of caffeine intake, and physical inactivity. So these are important risk factors. And I feel these last 4 risk factors that I talked about are often the low-hanging fruit, which may really help people.
Yeah. And I like to add also, I see a lot of times nutrient deficiency where certain electrolytes are not adequate in the diet. That can cause, because we need that for good, heartbeat regularity. And I also would add the link between acid reflux and vagus nerve stimulation and acid reflux and Afib that many people don't recognize too. I'd also like to say though, when we look at non-modifiable risk factors like age and genetics, I often see that yes, those do play a role, but there's usually other things that are modifiable that we can address that helps those things kind of stay at bay. So Afib is not as prevalent, or it is put into remission as well, because those 2 things alone usually aren't alone. They're usually accompanied by things that we can control. And so I always look at it from that perspective of what can we do through diet and lifestyle and treating sleep apnea appropriately and looking at all risk factor modifications.
Absolutely. And that's an excellent point that you bring up. What we traditionally consider non-modifiable, as we progress, we are understanding the mechanisms of atrial fibrillation. So although age is non-modifiable, the mechanism of how it produces atrial fibrillation or causes atrial fibrillation still remains a little bit modifiable. So that's an excellent point.
Yeah. So let's dive a little bit deeper into the non-traditional ones, and then we can talk a little bit about the traditional ones too. So you mentioned sleep apnea, and I think this is a really important topic because I don't think it's recognized as much as we need it to be recognized. And I also think the treatment of it a lot of times is, oh, I can't wear that mask, or I'm not going to go that route. And so what's the link? Let's start there. Why does sleep apnea increase the risk of atrial fibrillation?
Absolutely. And then sleep apnea is one of my favorite topics, partly because it is incompletely understood, part 1, and part B, there's a lot of misunderstandings about sleep apnea. Every time I bring up sleep apnea, my patients will tell me, oh, I sleep just fine and I sleep like a baby. So the important thing to recognize about sleep apnea is the most important factor there is where your body is not getting enough oxygen. You may be sleeping peacefully, but 1, your body is not getting enough oxygen. 2nd, your body may be showing some external signs of struggle to get more oxygen, like snoring is one of the symptoms of sleep apnea. But the most important part is the link. So when your body is not getting enough oxygen, your body secretes some sort of stress hormones to sort of try to make up for the lack of oxygen in your body. And some of these hormones that get secreted are also stress hormones, and they put more stress on the body in a way. They increase your blood pressure, and there's certain hormones like cortisol or angiotensin 2, and you don't have to remember any of this, fortunately, but cortisol, angiotensin 2, the oversecretion can lead to changes in heart structure by changing pressure dynamics inside the heart. What happens, the top chamber that we call the atria, they start enlarging a little bit, and their function actually changes, which we can evaluate with echocardiography or ultrasound of the heart. We can actually see those changes. And once we see the heart enlarging or the function changing, we can almost predict that this person is probably going to get atrial fibrillation maybe a few years down the line.
Yeah, so important. So, I've seen in my practice that sleep apnea goes undiagnosed a lot because someone says, I don't snore, or I don't know that I snore, or they're like, I'm not overweight, so I can't have sleep apnea. But they wake up multiple times at night, or they wake up with a really dry throat, or their blood pressure is very controlled during the day, but that morning blood pressure is extremely high, and no matter what intervention we do, it's not going to come down unless we treat sleep apnea. So then I'll recommend, we need to test this further. You're not the classic candidate of sleep apnea, but sleep apnea can be found in normal weight individuals, and individuals who don't have, you feel like you slept okay, you have energy, but it's still, there's some questionable accounting here. And so I think the first thing is we need to know if you have it. So what are some signs that people should look for to say, what, maybe this is an issue of mine, I should test this further?
Absolutely. And you bring up really good points, partly because, this is an everyday conversation, as a clinician, where you tell a patient, well, you may have this, and the first response is, no, I sleep well. No, I don't snore. I'm not overweight. So you're absolutely right about those conversations. My personal philosophy is, sleep apnea testing is much simpler now compared to 5 or 10 years ago, where you had to go and sleep in the sleep doctor's office, or sometimes, they would set you up in the motel, and you had to wear a ton of wires, and someone was watching you, and there's a video camera. But I think over the last 5 to 10 years, things have changed quite a bit. And getting sleep apnea testing is really simple. You can actually get some of those things online, even without your insurance, for like $150 to $200. If you have any risk factors, if you have high blood pressure, if you have family history of sleep apnea, if you have even a little bit of fatigue, or your partner tells you, hey, you know what, you snore a lot, I have to wake up. Or one of the commonest things that I hear is the partner telling, hey, I was watching you breathe last night, and it felt like you almost stopped breathing for a few seconds, and I had to wake you up. So these are the commoner things that would lead me to tell someone to get sleep apnea testing. But honestly, I think everyone should have sleep apnea testing. And I've changed my practice over the last 5 to 6 years. Because in the past, I'd be like, oh, let's see if you meet criteria. Let's see if you meet this score. And if you meet this score, I'll send you for sleep apnea testing. But over a period of time, I realized that sometimes you just need to have some clinical suspicion, and you need to get the test. And I'm actually surprised how many people turn out positive, even you don't score enough on the score for sleep apnea testing. And to be honest, I got tested myself a couple of years ago because my wife was like, you were snoring last night. Unfortunately, I was negative, but the test was so simple that I feel everyone should have it tested, even if you feel you're in good health. And some people may, argue that, no, that's over medicalization, that's over treatment. But the benefits of treating sleep apnea are really underappreciated.
Yeah. A couple of comments just because it's coming up. A lot of times people say to me, I only snore when I drink alcohol. Or they'll say, I don't feel like any different. I'm not going to do any of the treatment. Or, oh, my doctor said if I lose weight, then I don't need the treatment. And my philosophy is, and this is what I have read in the research, it's not, when you're trying to lose weight, a lot of times sleep apnea will prevent weight loss. And so treating it and then retesting it, you can get off the treatment of sleep apnea. It's not necessarily a lifelong treatment, but without it, it's very hard to control, to help with weight loss, because sleep is really important in terms of helping to lose weight and appetite and satiety, hormone regulation. And so sleep is a big piece of the cardiovascular puzzle, and we shouldn't neglect it. So there's no harm in getting treated and then testing again to see if you're good and you don't need it anymore. It's not necessarily something you need to do lifelong. And I think that that's important to recognize, because many people are nervous about the CPAP and nervous about all that. But, one thing that's important to also note, the CPAP isn't the only solution. Right now, there is a CPAP shortage. And so what are some other modalities that people can use if they have sleep apnea, just to help reduce that fear of, I don't want that, and knowing that there might be some other options that are important to discuss?
Absolutely. So now there's more and more devices coming out which can treat sleep apnea without the CPAP. One of them that comes to mind is Inspire, which I refer some of my patients to get it done. Also with the CPAP machines, there are more options with the masks, and there are better masks. There are easier masks to use. So first of all, we should explore that option. But if people are still not able to tolerate it, then an implantable device like Inspire is an option, which is almost like an implantable pacemaker that helps your breathing patterns. A lot of ENT physicians, the ear, nose, and throat physicians, do these implantable devices. We have some cardiologists who do it as well. So there are CPAP, there are options to CPAP. The first step is diagnosis.
Definitely.
And I think a lot of us are scared of being diagnosed with something. That's why we don't want the test done, because somewhere inside we know I actually have it, but I don't want the diagnosis.
Totally. But remember, if we can't manage and treat it, it increases your risk of a heart attack and stroke. So we're talking, and this goes from a cardiovascular standpoint, sleep is essential. You hear all about antioxidants and how an antioxidant-rich diet is so important. But remember, when you're awake, you're using a lot of oxygen. And so we produce free radical production just by being awake. When we're sleeping and having good restorative sleep, our antioxidant defense system is restored. And so it actually acts as a defense against excess oxidative stress. And if we're having sleep apnea and we don't know it, you're causing more oxidative stress to build up. And what happens with oxidative stress? We get inflammation, we get the plaque, the blood clots, the things that cause heart attacks to actually rupture, cause issues. And so sleep apnea, we might not want to be diagnosed, but I look at it from an empowered standpoint. More knowledge you know about your health, the more you can be empowered to take control. And the more empowered you can live your life and not have to worry about your health, right? A lot of times people come to me and say, I work out, I eat healthy, I don't know how I had a heart attack. And a lot of times it's so many risk factors that were never looked at. So please don't overlook your sleep. It is so, so important. So great. So sleep, we talked about sleep apnea. Make sure that it's good quality, good amount of sleep, important for Afib control and prevention of Afib, but really heart attack prevention and protecting your heart in all aspects. So you mentioned then alcohol and caffeine. So let's touch upon those, and then we can move into a little bit more of the others as well.
Absolutely. Yeah. And then alcohol is an interesting topic. We know for the most part, there's very little benefits of alcohol, a lot more risks. And a lot of people, when you say, oh, up to 2 drinks are okay, people are not stopping at 2 drinks sometimes, if you're doing it every day, and that's a downside. But in terms of directly the relationship between alcohol and atrial fibrillation, so what we typically say is up to 7 drinks a week is okay. And we'll go into details about what does a drink mean. So up to 7 drinks a week is okay. Between 7 and 14 drinks a week is a gray zone, and beyond 14 drinks a week, which is more than 2 drinks a day, increases your risk of atrial fibrillation. Now, people use different data, and then some data will say, well, more than 10 drinks a week increases your risk. So there's going to be a little bit of variability.
Can I ask for clarification though?
Yeah.
So I've seen, are you talking about in someone who doesn't have Afib or someone who's diagnosed with Afib?
So both. So in patients who don't, or in people who don't have atrial fibrillation, alcohol increases the risk of developing it. And people who actually have atrial fibrillation, it increases the risk of having repeat episodes of atrial fibrillation.
So in my practice with a lot of my clients who have Afib, I find that certain people, if they have a sip of alcohol, they'll go into Afib. And there's other people who can have 2 drinks and it doesn't necessarily affect them. But in general, I find that alcohol can stimulate an AFib episode. Can you talk about why that might be? What's the connection between our alcohol intake and why it would increase our AFib risk?
So alcohol is actually directly toxic to your heart cells. And they do cause excitability in the heart rhythm tissue as well. So based on that, it can induce atrial fibrillation by stimulating your heart rhythm tissue. In fact, there's a syndrome called holiday heart syndrome. So binge drinking of alcohol, especially, people who are in college or younger kids who go on binge drinking, vacations, holidays, and you would think, yeah, it's a 20-year-old person, what's going to happen to me? And some patients actually develop atrial fibrillation even after a night of binge drinking. So that's how toxic alcohol can be and can directly affect your heart. So that's the direct link between alcohol and atrial fibrillation.
Okay, yeah, because the more research that comes out, it's really showing any alcohol can cause that. And because with that explanation, it's important to understand everyone metabolizes alcohol differently. So it can cause more of that, so to speak, toxic load, depending probably on your weight, your ethnicity, a lot of factors. And so for one person, one drink is toxic to the cells, causing that irregular heartbeat versus someone who can tolerate 6 drinks in a week and be okay. In terms of type of alcohol, does that matter?
So not directly, but indirectly, it matters in a way because one drink will be almost 12 ounces of wine versus one drink is 1.5 ounces of liquor. So
you mean 5 ounces of wine, 12 ounces of beer?
Oh, no, sorry, 12 ounces of beer. That's
Yes.
right, 12 ounces of beer. Good catch. 12 ounces of beer, 5 ounces of wine, and 1.5 ounce of liquor constitutes a drink. So the total amount of your alcohol intake measured in terms of drink matters more than the quality as such. Having said that, there are some benefits with wine. So if I had a choice out of all of these, wine is probably a little bit lesser risk due to the polyphenols that are included in wine.
Okay. But like we said, it really is individualized, and many people benefit from no alcohol. There's no benefit. You can get polyphenols through your diet, which has a lot more benefit without any of the side effects. So I think that's great. What about caffeine intake?
So yeah, caffeine. And again, just like alcohol, caffeine is interesting, except caffeine has a lot of advantages. So, you always, if you are someone who's not looking into the details and you're just looking at the news reports or overall take on caffeine, you'll realize that every few months a new article comes out. One will say increases your risk of heart disease. 6 months later, something else will say, well, reduces your risk of heart disease. So what is it? So the thing with caffeine is low to moderate amounts of caffeine intake are actually protective against heart disease. They're protective against atrial fibrillation as well. But as we have been discussing, just like alcohol, individual effects may vary. There are some patients who will say, oh yeah, I had a drink of coffee and I went into atrial fibrillation right away. So typically my recommendation is a couple of cups of coffee a day are okay if you know that doesn't bring out your atrial fibrillation. There's one survey which surveyed patients with atrial fibrillation, and 25% patients actually reported that caffeine induced their atrial fibrillation. In those patients, I tell them, okay, in that case, avoid caffeine. But the rest, where it's not, or where they know it not to be a trigger, it's okay to drink a couple of drinks of coffee every day.
Yeah, I think it also has to do from a personalization point of your digestion. So many times caffeine can increase blood pressure in certain individuals, not everybody, but it can increase blood pressure, which is a risk factor for AFib. And on the other hand, there's some people who have vagus stimulated AFib, where caffeine can cause the esophageal sphincter that closes your stomach to your esophagus to open, leading to acid reflux or bloating distension that can also also trigger AFib. So I think that the 25% is probably in the people who have digestive induced AFib, where that's what causes that electrical disturbance from that episode. So what I always say with AFib is when it comes to diet, when it comes to caffeine, alcohol, a lot of it is personalization. And it's a lot of kind of digging in and seeing, when you had those AFib episodes, what caused it, what was happening, and assessing for patterns and being able to make sure that we are addressing all of that. Okay, great. So then you mentioned physical inactivity. Mm-hmm. How is that connected to AFib?
So physical inactivity, all of these risk factors sort of affect AFib directly, indirectly. So the direct effects of physical inactivity are obviously weight gain, uncontrolled hypertension, and just the general lethargy that you have, because physical activity increases a lot of good substances in your body. So in terms of physical activity, one question that comes up is, okay, how much is good and how much is too much? So if you look at the guidelines, they recommend almost 150 minutes of exercise every week should sort of protect you against cardiac issues, moderate intensity exercise. So that comes to about 30 minutes, 5 times a week is appropriate. Now, people who are worried about how much is too much, and that's different for everyone. But if you look at it, it's going to be people who are running 5 to 10 miles a day. And most of us are not doing that. That's less than 1% of the total US population. Most people, which I would say 90% people actually, and that's a surprising number, do not meet the 150 minutes guidelines. So I'd be more worried about getting those 150 minutes instead of the ones where you're doing too much.
Right. And remember what we said in the beginning, we're trying to avoid pooling of blood. And so if we're not moving, our blood is stagnant. It's not moving. And so it's more likely to pool and cause a stroke, cause a heart attack. And so that physical movement is imperative to optimal cardiovascular health in general. So we need to make sure that that's part of the regimen. So it's important that we're looking at all aspects when it comes to AFib. So we discuss sleep. We kind of discussed a little bit of stress within sleep, but stress is also a big factor in terms of atrial fibrillation. We talked about caffeine, alcohol. We talked about physical inactivity. Let's go into a little bit more of nutrition, but the diet in terms of the traditional risk factors, right? So you mentioned obesity. It's important to note that obesity is a risk factor, but it's not a requirement for AFib. Mm-hmm. I spend a lot of time in my practice mentioning this because I can't tell you how many cardiologists have dismissed my clients previously, like, oh, you're thin, nothing to worry about. You can have heart disease in every shape and size. And so we need to acknowledge that. So while obesity is a risk factor and we want to address it, we need to also understand that it's not a requirement, meaning that you can be thin and still have atrial fibrillation. But why would being overweight cause an irregular heartbeat? Why would that cause our body to go out of rhythm?
So obesity itself, it puts more stress on the heart. And as we discussed in terms of mechanisms, the top chambers of the heart start enlarging. If you're obese, your heart is unable to keep up with the requirements. And then obesity is associated with stiffness of the heart muscle itself. The ventricles, we call it diastolic dysfunction. But even as we understand more about obesity, even the atria, the muscles of the atria get stiff, and they become dysfunctional. That's the first thing. But what more recently we have been realizing is fat tissue that sits right on top of your heart, we call it epicardial and pericardial fat, can directly stimulate your atria into atrial fibrillation. And that goes back to your point of, okay, you're not obese by the traditional definition of your BMI and all of that, but where your fat is sitting, what kind of fat is it? What kind of cholesterol you have in your body? That is more important than just how you look. So those things, I agree with you. Seeing a nutritionist is critical. Patients will often ask me nutritional questions, and I'll be honest, sometimes I don't know, and it could be due to a little bit of cultural differences based on what foods I eat at home versus what my patients are eating. But a lot of it is, where when we spend time learning, we are doing mostly cardiac procedures, cardiac medicine. We don't have curriculum specific to nutrition. We may have a couple of chapters, we may read a few papers, but we don't spend years studying and learning about it. I am a big proponent of seeing a nutritionist. Even if you're healthy and you feel your diet is decent, I want you to see a nutritionist because there's so many things, like you mentioned, electrolytes and all of that, which sometimes people will ask me, hey, what about this food? I was like, you know what? That's a good question, but I'll have to look it up.
And I appreciate you saying that. You're a doctor, you're brilliant, you have so much knowledge, and I love working with so many of these brilliant cardiologists. And I think it's important to know that I'm not going to recommend medication. I'm not going to recommend certain things. It's not my scope of practice, but diet and nutrition is super important. And I want everyone to realize that we need to make sure when we're trying to optimize heart health that we're not pigeonholing into one type of diet. So some people will be like, oh, a doctor might say you need to lose weight in order to optimize your heart health. So they'll Google best way to lose weight, and then someone might go on the ketogenic diet. We know from research that ketogenic diets actually can cause Afib as well because of the high saturated fat content that can stimulate a heartbeat irregularity, but also because it's deficient in carbohydrates, which has essential nutrients that we need for optimal heartbeat regularity. So I'm very big about ensuring that we have a nutrient sufficient diet that's well balanced in complex carbs, heart healthy fats, lean protein. And that's also long-term sustainable. Your heart does not like yo-yo dieting. It does not like gaining weight, losing weight, gaining weight. It actually puts more pressure on the heart. And so we want to make sure that it's sustainable. It's also steady. So we're doing a slow and steady weight loss. But even if you don't have to lose weight, we need to make sure your body's getting all the nutrients it needs, like magnesium, potassium, calcium, through food. A lot of people will jump for a supplement, but potassium supplements can cause atrial fibrillation. High dose calcium supplements can cause plaque formation in your arteries. So we need to really be looking at this from a nutrition sufficient diet and making sure, like you said, it's personalized. What you eat and what I eat might be totally different, but it still could be heart healthy. You can be on any diet really, as long as it's balanced and getting the micro and macronutrients and be successful. And it needs to be culturally accepted. You need to still love the food that you're eating. You need to make sure that it's resonating, because that's the only way it's going to be long-term sustainable. And when we're talking about Afib, we're talking about heart health, it needs to be long-term, because you don't have a blood clot overnight. You don't have a stroke overnight. It's over months, years, and decades of your life of lifestyle and nutrition that can cause these things. So we need to be empowered to take control and to do small steps at a time. Don't do everything overnight. It's not going to stick. And it's also it's not realistic. So I'm very big about sustainability and really personalization and making sure we're addressing everything. And making sure you're getting all of those vitamins and nutrients for optimal heart health. So important. The last thing I want to mention, because I know we're short on time, is high blood pressure. So we know that that's a traditional risk factor. Why would high blood pressure cause your heartbeat to go out of rhythm?
Absolutely. So again, with the high blood pressure, there's stiffening of the heart, and then the top chambers start getting enlarged because of the high pressure. So when you think of high blood pressure, it's often misunderstood, partly because people think of, oh, the heart is beating too hard, causing high blood pressure. And it's actually quite the opposite, where what happens is your blood vessels or your microvasculature is clamping down, raising your blood pressure. So if you actually have high blood pressure, your heart has to pump harder against that pressure. Thus, the pressure inside the heart has to go up in response to your blood pressure rather than the other way around. And that high pressure can then cause stretching of the pathways of your heart rhythm system and induce atrial fibrillation.
Yeah. It's so high blood pressure is one of those things though that you don't feel your heart getting bigger. You don't feel your high blood pressure. So, and you can go to the doctor once a year. Some people don't go for 5, 10 years. They never know that they have high blood pressure. How do we make it more of a universal thing to know? Because it's so important and it does a lot of silent damage without us realizing.
Beyond the age of 40, until the age of 40, your body is not as salt responsive. But once you sort of go beyond the age of 40, your body really becomes salt responsive. You increase your salt intake, your blood pressure goes up. So I tell everyone beyond the age of 40, unless there's a good reason for you to have more salt for a specific medical condition, you should limit your salt intake. But also check your blood pressure. It's so easy to check your blood pressure at home a couple of times a month. You don't have to do it every day, or even once a month in the right settings. Just keep an eye on it. And if you start seeing it creeping up, there's lifestyle measures you can do. First of all, it's going to be the nutritional changes that you have to make, and then eventually medicines. But just get a blood pressure cuff. You can buy it off online or CVS for $20 to $30. And even the cheapest cuff performs as well as some of the expensive ones. You don't need all the fancy things on your blood pressure cuff.
Yeah, I agree. We need to make sure that we're testing it. Is there a time of day that's more important than others?
Yeah, usually what I tell people is settle down in your day. And typically, most of us are in busy lives. We don't have 5 minutes where we can settle down. Don't do it the first thing in the morning because your cortisol levels are high, raises your blood pressure a little bit. So typically have your breakfast, 8:39. If you can find that 10-15 minute window where you can sit, relax, that would be an ideal time. And often you want to compare apples to apples. Don't check it at 9:30 one day and 4:30 the next day, because it will stress you, because there are going to be diurnal variations in your blood pressure, and that's a natural pattern. So check it between 8 and 10 in the morning when you're relaxed, not stressing, when you have had enough food in your belly. And there's specific ways that you should check your blood pressure, where you should where your arm should be, and where your cuff should be, and all of that.
Yeah. And what's our target?
So target is you want it below 130/70, up to 140/80 is acceptable. But once you're getting to that level, you're already pre-hypertensive. And then a lot of it gets confusing and overwhelming for patients, because now you have two numbers. My bottom number is 84, my top is 124. Should I be worried about it? And so the more and more research that we have done is showing that the systolic is probably easier to follow, more reproducible, and easier to target. Some patients do have isolated diastolic, which is the bottom number, isolated diastolic hypertension. And that's not as big of a risk factor as we thought it was in the past. So I tell patients to focus on the top number, focus on keeping it below 130. You don't need medicines until you're getting over 140. Once you start getting over 140, you are hypertensive and you probably will need some medicines.
Yeah. There's been some recent guidelines that say like 110/70 is your ideal blood pressure. But really aiming for 120/80 and less is really a target point. And if you're creeping up, that's where lifestyle intervention is vital. So you won't get necessarily medication to assist until it's a certain level. But you can optimize your lifestyle and your nutrition in that time frame to help bring it into normal values. There's also been some studies that show that if persistently your blood pressure is above 130/80, it can cause some structure changes in the arteries as well. So we want to be mindful of it and intervene as we can, because high blood pressure can cause a lot of damage. I've seen people who've had normal lipids their whole life, but they had undiagnosed high blood pressure for over 10 years and they had high CAC scores. And a lot of research actually is showing the high blood pressure can lead to coronary artery disease as well, Afib, cardiomegaly, your enlargement of your heart failure. So we want to make sure that you know your numbers and you're taking action to optimize them to really protect your cardiovascular health. This was great. I really enjoyed our conversation. I think it was jam-packed with some really great tips and information. I hope everyone enjoyed it. If there's one thing you want people to take away from all of this information, or any last words that you'd like to share with us, I'd love to hear them as well.
Absolutely. So what I tell my patients is prevention is a team sport. It's not one person just seeing a cardiologist once in 2 years isn't going to help you prevent heart disease. It's a team sport. You see your physicians, you see a nutritionist, you exercise regularly, hopefully with a trainer, because they really help you out, and then optimize all other metrics in your life as well, like sleep apnea, your blood pressure. And so there's multiple people who will be involved, multiple factors that will be involved. A lot of patients just show up once a year and expect to get some medicines to treat their cholesterol levels and hope that things will be fine and better, and it's not. So I want people to do more than just that.
Right. And at the end of the day, we can all guide you and support you, but you need to be motivated to help with those changes and work with the professionals and communicate and take ownership of your health, because you're the only one in control of your health. We can guide you, but at the end of the day, it's you who can be empowered to own this and really live a long, healthy life wherever you are in your heart journey. Thank you so much for being here. I want everyone to follow. I'm going to put your Twitter handle here. Everyone should follow Dr. Dabhedkar. And thank you so much for being here. This was lovely. I appreciate it.
Thank you. My pleasure. It was fun chatting, and I learned some new things. That's why I tell everyone, go see a nutritionist. No, thank you. Thanks for having me.
Thank you so much. Be well.